Nephrotic syndrome, it is characterized by massive heavy proteinuria greater than 3.5 grams of protein per day excreted. Next, hypoalbuminemia, if you lose albumin, and because of that there is decrease in oncotic pressure, there is edema. Then there is hyperlipidemia, lipiduria, and also hypogammaglobulinemia, if you lose gamma globulin proteins in the urine. So first, pathophysiology, there is massive proteinuria. There is damage to the glomerular capillary walls, which increases the permeability of the glomerular capillary wall to plasma proteins. So the major protein lost is albumin. It is a low molecular weight protein. Rarely globulins are lost. Okay. So AG ratio, it is due to variations are due to selectivity of proteinuria. Okay, so daily loss of greater than 3.5 grams or more protein, less protein in children in the urine. Next, if you lose albumin, then there is hypoalbuminemia, less albumin in the blood. Because of that, it decreases the colloid osmotic pressure, and because of that, there is generalized edema. Okay, and again sodium and water retention, decreased plasma volume reduces, because fluid is going into interstitial space, there is decreased intravascular volume which causes GFR to reduce, and then this causes compensatory secretion of aldosterone. There is sodium and water retention. Next, the characteristics of edema, it is soft and pitting, most marked in the periorbital regions and dependent portions of the body. Here you can see periorbital edema. And again there is hyperlipidemia and lipiduria, because most patients with nephrotic syndrome, they have raised blood cholesterol levels, triglyceride cholesterol levels, and LDL levels, LDL receptor, LDL lipoprotein levels, etc. Hyperlipidemia is due to increased synthesis of lipoproteins in the liver, abnormal transport of the lipid, and decreased catabolism of lipids. Lipiduria, see, hyperlipidemia is followed by leakage of lipoproteins across the glomerular capillary wall. The lipoprotein is reabsorbed, and then free fat, it appears in the urine as in the form of free fat or oval fat bodies when it is shed along with the degenerated cells. So the major complications are coronary atherosclerosis. So hyperlipidemia predisposes to atherosclerosis of the coronary artery. Next, nephrotic patients are highly susceptible to infection, especially staphylococcus and pneumococci. This is due to loss of immunoglobulins in the urine. You lose gamma globulins, right? Hypogammaglobulinemia. And you have thrombotic and thromboembolic complications because you lose antithrombin 3 in the urine. Okay, so here you can see highly selective proteinuria. In this, you lose only low molecular weight proteins less than 100 kilodaltons, such as albumin, transferrin, etc. in minimal change disease. Non-selective proteinuria, you lose high molecular weight globulins also, gamma globulins, immunoglobulins, etc. in membranous nephropathy. So this is the flow chart. And again, NPHS gene mutations, nephrin mutations. There is congenital nephrotic syndrome. NPHS 2 gene mutations, NPHS gene 2. There is Poderson mutation, acquired steroid-resistant nephrotic syndrome. Okay, CAD infections, thromboembolism, the complications are susceptibility increases. And again, the causes of nephrotic syndrome, the most common systemic causes are diabetes, amyloidosis, and SLE. Most important primary glomerular lesions are minimal change disease, membranous glomerulopathy, and FSGS. Okay, so here you can see primary glomerular diseases and secondary. See, membranous nephropathy, what happens is, it is characterized by uniform diffuse thickening of the membrane. So, basement membrane, where is it present? Glomerular capillary wall. So, it is there is uniform diffuse thickening of the glomerular capillary wall. This is due to the accumulation of electron-dense deposits along the subepithelial side of the glomerular basement membrane. So, membrane, okay, think of this membrane, and this is epithelium, right? So subepithelially you have membranous nephropathy deposits. So what are depositing? Complexes, antigen antibody complexes. Membranous nephropathy is the commonest cause of common cause of nephrotic syndrome in adults. So etiology, there primary or idiopathic, no identifiable cause. Secondary, see, secondary you can have drugs, okay, SLE, NSAIDs, SLE, and again neoplasms, and again syphilis, schistosomiasis, hepatitis infections, and again salt. So salt, SLE, drugs, Hep B, Hep C, tumors. Okay. Next, pathogenesis. So what happens is, remember this trick. So a man named Max. So man, okay, Hayman nephritis. It is an example of Hayman nephritis. It is an example of experimental model of membranous nephropathy. So Mac. Okay, the name of the man is Mac. So Mac is membrane attack complex. That is what is doing the damage. So there is no glomerular inflammation, but interstitial inflammation is there. Okay, so plant is there on the plateau. Okay, so plateau, it is plateau R. Against the plateau R antigen. Okay, antibodies are formed. So Plant is for name that it is a planted antigen. Okay, that's it. So pathogenesis, idiopathic, it is an autoimmune disease caused by autoantibodies reacting in situ to an endogenous or planted glomerular antigen. Against a planted glomerular antigen, there are antibodies. So especially plateau on the podocyte, it results in situ formation of immune complex. Hematonephritis is an example. So secondly, there are circulating immune complexes, and the antigens may be exogenous as in hepatitis B or treponema, and endogenous as in non-renal antigens like thyroglobulin or renal antigens. So mechanism, glomeruli do not show any inflammatory cells. There is formation of subepithelial immune deposits which activates the complement system and generates C5b9 membrane attack complex. This damages the podocyte of the glomerular epithelial cells and mesangial cells, liberates proteases and oxidants, and causes capillary wall injury, causing leakage of protein. Okay. Again, this leaked protein, the tubular epithelial cells, they resorb it. So they show droplets of resorbed protein in the tubules. Later, they undergo atrophy because of MAC. Next, glomeruli. See that the glomeruli are normocellular. Okay. Next, they show uniform diffuse thickening of the glomerular capillary wall. There are normocellular glomeruli, no proliferation or inflammation. Next, special stains. You can use silver stains or periodic pass stain to show characteristic spikes in the glomeruli between the deposits of immune complex. Next, interstitium, you can see in mononuclear cell inflammatory infiltrates and blood vessels. Early stages, they appear normal. Electron microscopy, again you can see thickening of the glomerular capillary wall due to irregular electron-dense deposits of immune complexes subepithelially. The visceral epithelial cells show effaced podocytes, foot processes. So in between these immune deposits, basement membrane material is laid down, which appears as spikes, irregular spikes. So you can see 4 stages in the subepithelial immune complexes. First, what happens is capillary walls are normal, or they show mild thickening and subepithelial dense deposits. You can see subepithelial dense deposits. Stage 2, what happens is there is glomerular basement membrane like material around the dense deposits that appears as spikes. Okay, like this. Next, stage 3, what happens is the glomerular basement membrane, it encircles the deposits and it is laid over the immune deposits. Then it appears in a dome, like a dome. Next, stage 4, what happens is these immune complexes, they undergo degradation and lysis, leaving cavities within the glomerular basement membrane. So if the deposition of basement membrane matrix continues, there is progressive thickening of the basement membranes. And immunofluorescence, you can see granular deposits of both immunoglobulins and also complement because of IgG, okay? Because of MAC, okay, in the subepithelial region. Next, there is also intense staining for MAC, membrane attack complex. It presents as sudden onset nephrotic syndrome. There is non-selective proteinuria because it is membranous nephropathy and it does not respond to corticosteroid therapy. Minimal change disease, it is named so because on light microscopy there are no appreciable changes, but only in electron microscopy you can see effacement of foot processes. So the glomerular changes are absent or minimal, and glomeruli appear normal under electron microscopy, but under light microscopy, but under electron microscopy you can see diffuse effacement or loss of foot process of the visceral epithelial cells or the podocytes. Minimal change disease is the major cause of nephrotic syndrome in children. Okay. So peak incidence is between 2 and 6 years of age. Etiology and pathogenesis. So the pathogenesis is unknown. The electron microscopic changes indicate that primary injury is to the podocytes. Okay, it may be because of an immunological mechanism, because MCD responds to steroids. Minimal change disease responds well to glucocorticoids. And also it follows a respiratory infection or routine prophylactic immunization. And again, it is associated with allergic disorders, and there is increased incidence in patients with Hodgkin lymphoma, where there is T-cell mediated immunity defect, and also prevalence in certain HLA haplotypes. Again, non-immunological mechanisms. Again, there is mutation in nephrin and podosin. Okay, this leads to structural defects. Mutation in the nephrin gene, it is found in hereditary type of Finnish type of congenital nephrotic syndrome. There is minimal change glomerular morphology. Okay, so MCD, mechanism of proteinuria. So there is loss of glomerular polyanions. Because of the defect in charge barrier, it allows anionic proteins which are normally repelled to get out into the urine. There is massive proteinuria, especially albumin. So morphology, minimal change disease is also called lipoid dystrophy, I think. Lipoid nephrosis. Because the tubules, they contain lipid vacuoles and glassy hyaline protein droplets. They reabsorb protein and lipids, so that is why lipoid nephrosis is the original term. and in light microscopy that you can see in the tubules. Glomeruli appear normal. The gross examination you can see kidneys that are mildly enlarged, that's it, because interstitium it shows mild edema, blood vessels are normal. Electron microscopy, effacement of the food processes, that's it. Glomerular basement membrane appears normal without any deposit. Immunofluorescence, it does not show any immunoglobulin or complement deposits. Classically it presents as nephrotic syndrome. It is preceded by upper respiratory tract infection or immunization. Proteinuria is highly selective. In other features, you can see generalized edema, hypoalbuminemia, but the renal function remains good and the prognosis is excellent. Moving on to FSGS, so in the name itself, there is sclerosis. So hyalinosis and sclerosis are seen in light microscopy. So as per the name, see, focal, okay, only few glomeruli are involved, and as for some part of the glomerulus is involved, some segment, okay. So classification, primary idiopathic causes, and secondary you have viruses, HIV infection, drug addiction, drugs, HIV, okay, and also sickle cell disease and massive obesity. So there could be congenital causes such as unilateral agenesis of the kidneys and acquired reflux nephropathy. So hereditary forms, autosomal recessive form can be seen due to mutations in the NEFS2 gene, okay, which maps to chromosome 1q2531, QQ, okay, 1q2531, which encodes podosin. So there could be inherited mutations in genes that encode podosin, alpha actin 4, etc. But adult onset FSGS is with mutations in TRPC6. Next, pathogenesis. So it is caused by an unknown injury to the podocytes. So according to some people, MCD and FSGS are part of a continuum, and that MCD progresses to FSGS. Both show visceral epithelial damage, that is diffuse effacement of the food processes of the podocytes. In FSGS, the deposition of hyaline in the glomeruli is due to the entrapment of plasma proteins and lipids in foci of NCD where sclerosis develops. Okay, next, morphology, light microscopy. First, you can see primarily FSGS involves only the juxtamedullary glomeruli, and then it progresses onto the cortex. It affects all levels of the cortex. Next, microscopy, you can see increased mesangial matrix. If matrix increases, you call it sclerosis. And hyalinosis, because there is deposition of hyaline or proteins, homogeneous eosinophilic material in the glomeruli. Next, obliterated capillary lumina because of hyalinosis and sclerosis. And again, hyalinosis represents leaked plasma proteins, and again, FSGS, F stands for foamy macrophages, lipid-laden macrophages. So in advanced stages, as the FSGS progresses, the sclerosis of the glomeruli involve other glomeruli. There is global sclerosis, and there will be pronounced atrophy of the tubules and fibrosis of the interstitium. Tubular atrophy and fibrosis of the interstitium. And collapsing glomerulopathy, the lumen collapses, the glomerular tuft is not there. So it is seen in severe HIV infection and drug-induced toxicities. There is collapse of the glomerular tuft and epithelial cell hyperplasia. Okay. Next, electron microscopy. Both you can see diffuse effacement of food processes. Okay, as in MCD. Immunofluorescence usually shows non-specific trapping of immunoglobulins, usually IgM, and complement in the areas of hyalinosis. Next, clinical courses. So both presents with nephrotic syndrome, FSGS and MCD, but hematuria and hypertension is more frequent in FSGS. And FSGS shows poor response to corticosteroid therapy, whereas MCD shows good response to steroids. And FSGS associated proteinuria is non-selective. MCD it was selective. Okay, urine findings, you can see proteinuria, oval fat bodies and fatty casts. Okay, children have a better prognosis than adults. So that's it. Membranoproliferative nephritis, glomerular nephritis. So remember, membranous nephropathy, there was subepithelial, okay? Whereas here it is subendothelial deposit. So basically membranoproliferative, right? So membrano means there is thickening of the glomerular basement membrane in the name itself. Proliferative refers to the fact that the proliferation is there of mainly mesangial cells, but because of that there is hypercellular glomerulus, and hypercellular is also because of leukocyte infiltration. It is also called mesangiocapillary glomerular nephritis because the proliferation is mainly mesangial cells and involves the capillary loops, okay, the thickening of the basement membrane. There are subendothelial deposits. So etiology, it is idiopathic primary, and it was divided into type 1 immune complex deposit type and type 2 because of dense deposit disease. It belongs to C3 glomerulopathy now. Secondary, it can develop in association with systemic disorders. Now, pathogenesis of MPGN. So previously it was known as type 1 MPGN. So immune complexes are deposited in the subendothelial zone of the glomerulus. Okay, so type 1 MPGN may be caused due to deposition of circulating immune complex or formulation of in situ immune complex against a planted antigens. So glomeruli, you can see large and hypercellular glomeruli because of mesangial and endothelial cell proliferation, mainly mesangial, infiltration of leukocytes, and also membranoproliferative, you can see epithelial crescents. Next, you can see hypersegmentation or accentuation of the lobar architecture. So it is because of increased mesangial matrix and due to proliferating mesangial cells, there is thickening of the glomerular basement membrane, membrano, okay. and subendothelial immune complex deposits, they cause synthesis of new basement membrane. It produces duplication of the basement membrane. See, there is accentuation of lobar architecture or hypersegmentation. Okay, so the basement membrane splits into two, and the mesangial cells, they proliferate. They cause a tram-tack appearance. Okay, it can be best appreciated by past stain. Okay, the splitting is due to extension of the mesangial processes and the inflammatory cells into the peripheral capillary loops, and the deposition of the mesangial matrix and subepithelial immune complexes. Next, tubules. The tubules may show vacillation and droplets of hyaline. Interstitium. See, inflammation is there. It is there in interstitium also. Next, blood vessels. During early stages, they are normal, but later they may show changes due to hypertension. And there are subendothelial electron dense deposits in electron microscopy. And immunofluorescence, C3 is deposited in a granular pattern. Okay, so dense deposit disease, if it is there, it is a C3 glomerular nephropathy. And also it suggests activation of the classical complement pathway. Age, it is mostly found in adolescents or young adults. It presents with nephrotic syndrome. Some only with hematuria or proteinuria in the non-nephrotic range, but there is a combined nephrotic-nephritic picture. So urine findings, there is proteinuria, oval fat bodies and fatty casts. It is slowly progressive and 50% develop chronic renal failure. Some may develop crescent, some may develop RBGN. Moving on to C3 glomerulopathy, it consists of two conditions, dense deposit disease and C3 glomerulonephritis. Both are similar, but only the electron microscopic findings are different. So pathogenesis, both are caused due to complement dysregulation, either due to acquired or hereditary abnormalities of the alternative pathway of complement activation. Okay, so this is because, see, there is decreased serum C3 because that directly acts in the alternate pathway, but normal C1 and C4 which act before C3 in the classical pathway. So normal C1 and C4 decrease serum C3, and there are decreased levels of factor B and properdin, which are the components of the alternate complement pathway. C3, factor B and properdin levels are decreased. And in the alternate pathway, C3 is directly cleaved to C3b. The glomeruli show deposits of C3 and properdin but not IgG. So sequence of events. So what happens is, in the alternate pathway, C3, so polysaccharides, endotoxins, etc., they cause the C3b to be bound to that endotoxin, etc. Okay, this bound C3b, it cannot be degraded. So what happens is factor B acts on it, and factor D, it splits factor capital B into capital B small b and small b. So capital B small b, it combines. So this acts as the C3 convertase of the alternate complement pathway, and it splits C3 into C3A and C3b, and the C3b enters the classical component cascade. Okay, so it is, see, this C3BBB, the C3 convertase, it is stabilized by properdin, okay, to keep acting on C3, so that complement activation keeps on going. Whereas factors I and H, they break this down so that C3 remains in the blood. Okay, there is dysregulation, so this is continuously activated because of mutations in C3 nephritic factor C3-Neph. So there is an autoantibody against C3 convertase, due to which the action is prolonged. It stabilizes this and it keeps acting on C3, breaking it down, etc. So this is the sequence of events. C3b in the presence of B and D generates C3BBB, which is the alternate pathway convertase. It is labile and degraded by I and H, but stabilized by properdin. So in some patients, there is C3 nephritic factor, which acts like properdin. It's a stabilizer, and it prevents the degradation of the convertase. This results in persistent and prolonged C3 activation and hypocomplementemia by C3-Neph. Okay, in addition, there is decreased synthesis of C3 by the liver, also responsible for hypocomplementemia. Next, there also could be mutations in factor H, factor I, MCP, etc., and also autoantibodies to factor H. So light microscopy, the glomeruli are hypercellular. There is duplication of basement membrane, mainly mesangial proliferation with increase in mesangial matrix. All is same as type 1 MPGN. And you can see focal crescents, okay. In some cases, they show dense deposits of a cellular material in the glomerular basement membrane. It resembles dense deposit in the GPM. Next, electron microscopy, C3 glomerulonephritis. It shows mesangial and subendothelial electron dense waxy deposits. Dense deposit disease in the lamina densa and the subendothelium densa, EN, okay, and subendothelium, EN. You can see that it is transformed into an irregular ribbon-like extremely electron dense structure resulting from the deposition of C3 containing material. So immunofluorescence, you can see bright C3 staining in the mesangium and glomerular capillary wall. Okay, and clinical features, they're usually younger patients with dense deposit disease, and they have low serum C3 levels than patients with C3 glomerulonephritis. It presents as nephrotic syndrome with hematuria or nephrotic syndrome with proteinuria, similar to MPGN. Both have poor prognosis. Okay, and dense deposit, both these diseases are due to activation of the alternate pathway. So Alport syndrome, the electron microscopy is diagnostic, and it shows basket weave appearance of the glomerular basement membrane. So So it is a type of hereditary nephritis. There is abnormal alpha-3 col4A3 and alpha-4 collagen 4A4 or alpha-5 col4A5 chain of type 4 collagen. Type 4 alpha-3 alpha-4 alpha-5 collagen defects, and basically there is nerve deafness, eye disorders, and foamy cells in the interstitium. Hematuria can progress to chronic renal failure. Moving on to IgA nephropathy, it is one of the most common causes of recurrent microscopic or gross hematuria. It is the most common type of primary glomerular disease revealed by renal biopsy, and the microscopic characteristic feature is IgA deposition in the mesangium. IgA deposits in the mesangium. IgA mesangium. Okay. So etiology and pathogenesis. So IgA is the main immunoglobulin present in mucosal secretions. So in plasma it is present in low concentrations, and abnormally glycosylated IgA1, that is galactose deficient, abnormally glycosylated galactose deficient Gd-IgA1 immunoglobulin is probably involved in the pathogenesis. So there is HLA susceptibility in identical siblings, and so pathogenesis, basically what happens is that there is a triggering event such as an upper respiratory or GI tract exposure to microbes or other pathogens, okay, which triggers the increased synthesis of IgA. Some of this IgA is abnormally glycosylated galactose deficient Gd-IgA1. It results in the formation of immune complexes in situ, whereas increased synthesis of IgA elicits an autoimmune response to produce autoantibodies against this IgA. So this also causes immune complex formation. So these immune complexes, they deposit in the mesangium, and this leads to activation of the alternate complement pathway leading to IgA nephropathy. Morphology, you can see immunofluorescence showing mesangial IgA deposits, and electron microscopy shows electron dense deposits in the mesangium. That's it. Okay, so this is the pathogenesis. So the presence of C3 in the mesangium and the absence of C1q and C4 points to activation of alternate complement pathway in the pathogenesis. So this is supported by the fact that frequency of IgA nephropathy occurs in individuals with celiac disease, okay, and in liver disease. So few considered IgA nephropathy as a localized variant of Henoch-Schönlein purpura, which also shows IgA deposition in the mesangium. However, this is a systemic syndrome, and it also involves the skin. There is a purpuric rash and GI tract, so abdominal pain and joints, arthritis is there. So microscopic changes are variable. The glomeruli may appear normal or may show mesangial whitening due to IgA deposits in the mesangium and segmental inflammation, and there is diffuse mesangial proliferation or frank crescentic glomerular nephritis. So immunofluorescence, you can see mesangial deposits of IgA, usually with C3 and properdin, and smaller amounts of IgG or IgM. And classical complement pathways such as C1 and C4, they are not seen. Electron microscopy, it shows dense deposits in the mesangium. So it usually occurs in children and young males who present with painless or asymptomatic microscopic hematuria, recurrent macroscopic hematuria within 1 to 2 days after a non-specific upper respiratory or gastrointestinal viral infection. So hematuria periodically recurs usually in occurrence or association with a viral infection. Okay, so it may present as acute renal failure. So diagnosis is by renal biopsy. Immunofluorescence shows prominent IgA deposits in the mesangial regions. And course and prognosis is usually good, but risk of development it slowly progresses to end stage renal failure in 25% of patients over 20 years. So poorer prognosis, it is indicated by diffuse mesangial proliferation, segmental sclerosis, endocapillary proliferation, etc. Chronic glomerular nephritis. So what are the causes? So basically you have RPG, and then you have membranous nephropathy, membranoproliferative glomerular nephritis, IgA nephropathy, FSGS, and also post-streptococcal glomerular nephritis is a rare cause. And moving on to the short note, it is also called end-stage kidney. Chronic glomerular nephritis is an end stage of many types of glomerular nephritis. So gross, there is contraction of the kidney. So both kidneys, they show symmetrical contraction. There is diffuse granular cortical surface. And on cut section, there is thinning of the cortex and increase in peripelvic fat. The capsule is difficult to remove because of adhesions. Capsule is difficult to remove. There is contracted kidney with cortex is granular, etc. And microscopy, glomeruli. See, there are acellular masses. So you can see hyalinization of the glomeruli. And again, early stages, it shows features of the primary disease. Late stages, you can see obliteration of the glomeruli, hyalinization of the glomeruli, which appear as acellular eosinophilic masses consisting of plasma proteins, and increased mesangial matrix, hyalinosis and sclerosis, etc. Proteins and matrix. Next, there is atrophy of the tubules, acellular masses or obliteration of the glomeruli, and fibrosis of the interstitium, and mononuclear leukocytic infiltration. Blood vessels, there is hypertension which develops in patients with chronic glomerular nephritis, and the vascular changes of hypertension such as arterial and arteriolar sclerosis may be seen. So there are uremic complications as well, such as uremic pericarditis, uremic pneumonitis, which is diffuse alveolar damage, DAD, uremic gastroenteritis, secondary hyperparathyroidism with nephrocalcinosis and renal osteodystrophy and left ventricular hypertrophy due to the hypertension. So clinical course, it is of insidious onset. It progresses to renal insufficiency or uremia during a span of years. Most patients have hypertension and may present with hypertension-induced cerebral or cardiovascular diseases. So non-specific complaints are there: appetite loss, anemia, vomiting, etc. It may be detected during routine medical examination. So azotemia is elevation of BUN and serum creatinine. So these are the features. And finally, lupus nephritis. You can see kidney changes in SLE. They are known as lupus nephritis and they are seen in up to 50% of patients. So it's an immune complex mediated type 3 hypersensitivity reaction. The main mechanism is immune complex formation, which consists of DNA and anti-DNA bodies, and morphology we've discussed. Moving on to diabetic nephropathy. So it is a term used for collective lesions that often occur together in the diabetic kidney. So it can develop in both type 1 and type 2 diabetes. So pathogenesis. So basically, insulin deficiency, hyperglycemia and metabolic defects, they cause biochemical alterations and they lead to formation of AIDS, so advanced glycation end products. So non-enzymatic glycosylation and formation of AGEs. What happens is these AGEs cause increased extracellular matrix synthesis, increased ROS, reactive oxygen species, and they cause cross-linking of the extracellular matrix proteins such as cross-linking with collagen type 4, which results in thickening of the glomerular basement membrane and increased mesangial matrix. So increased GCM, increased ROS, and cross-linking, which causes thickening of the basement membrane. Next, there are hemodynamic changes which cause glomerular hypertrophy, and they may also be responsible for the initiation and progression of diabetic glomerular sclerosis. Both AGEs and hemodynamic changes contribute to loss of podocytes. And finally, there are disturbances in polyol pathways which increases the susceptibility to ROS. Okay, so ROS, loss of podocytes, and basement membrane thickening, increased matrix. Next, renal lesions in diabetes, we need to remember that in diabetic nephropathy, the kidneys are the main targets of diabetes. So renal lesions, they can be classified into glomerular lesions, renal vascular lesions, mainly diabetic arteriolosclerosis, pyelonephritis, including necrotizing papillitis, which is quite specific somehow to diabetic nephropathy, and tubular lesions. So glomerular lesions, basically you can see glomerular basement membrane thickening, okay. And then take M, you can see mesangial sclerosis, and also reverse the M, you get a W, so Wilson or Kimmelstein-Wilson's nodular sclerosis. Okay, those are the glomerular lesions. So you can see thickening of the GBM, diffuse mesangial sclerosis, and nodular glomerular sclerosis, KW nodules. So diffuse widespread thickening glomerular capillary basement membrane. It occurs in almost all cases of diabetic nephropathy. Next, diffuse mesangial sclerosis. It is characterized by diffuse increase in pars-positive mesangial matrix and mesangial cells. Next, nodular glomerular sclerosis. It's also called intercapillary glomerular sclerosis or Kimmelstein-Wilson disease, and it is pathognomic. So KW lesions, they develop in 15 to 30% of long-term diabetes, and it is mostly associated with renal failure. See, it consists of ovoid or spherical, often laminated nodules of mesangial matrix seen within the mesangial core. Okay, in the mesangial matrix, within the core, situated in the periphery of the glomerulus, and these nodules are surrounded by peripheral capillary loops. Okay, these nodules are surrounded by peripheral capillary loops with patent or dilated lumen. Okay, the nodules are pars positive. As you can see, these nodules are pars positive. So as the disease advances, these individual nodules, they increase in size and they compress the surrounding capillaries. Okay. Next, incidative lesions. See here, you can see Kimmelstein-Wilson nodules surrounded by the capillaries. And finally, outside the capillaries within the glomerulus, you can see fibrin caps. And attached to the epithelium, you can see capsular drops, okay, projecting into the Bowman's capsule. So, Bowman's waste. So, fibrin caps are prominent subendothelial accumulations of hyaline material along the capillary loops. And capsular drops are round nodules adherent to the Bowman's capsules and are seen between Bowman's capsule and the parietal epithelium. Renal vascular lesions, again you can see renal hyalinosis or hyaline arteriolosclerosis. So the afferent and efferent arterioles both are involved, and efferent arteriolosclerosis is rare in non-diabetics. So mainly efferent arteriole you need to see. And also renal atherosclerosis, it involves arteries and arterioles and are similar to those found in other parts of the body. So both lesions together produce renal ischemia leading to atrophy of the tubules, interstitial fibrosis and contraction of the kidney. Pyelonephritis. So basically both acute and chronic pyelonephritis occurs in diabetics as well as non-diabetics. It is more common and tends to be more severe in diabetics. So there is necrotizing papillitis or papillary necrosis. It is one of the most special patterns of acute pyelonephritis, more frequent in diabetics. So hyaline arteriolosclerosis narrows the blood vessels, reduces the blood supply to the medulla. There is ischemia causing necrosis of the tips of the papillae. So papillary necrosis. Tubular lesions, so you can see epithelial cells of the PCT which show extensive vacuoles of glycogen. They are called Armani-Epstein lesions. So there is thickening of the lamina densa, there is increase in the mesangial matrix, and insidative lesions they appear. And immunofluorescence microscopy, it shows IgG, albumin, fibrinogen, and other plasma proteins in the GBM. Amyloidosis, the kidney is the most common and serious form of organ involvement in amyloidosis. For diabetes, you can have non-nephrotic proteinuria, nephrotic syndrome, and chronic renal failure. So pathognomic lesion is Kimmel-Steen-Wilson nodule. Causes of necrotizing papillitis, you have diabetes mellitus, you have sickle cell anemia, obstructive uropathy, and analgesic nephropathy. Okay, so liver fatty acid binding protein is a biomarker of diabetic nephropathy and chronic kidney disease, LFAB-B. So microalbuminuria is seen in diabetes, especially excretion of 30 to 300 mg of albumin within 24 hours, and microalbuminuria is the first laboratory sign of diabetic glomerulopathy. Okay, Armani-Epstein lesions, the PCT cells with glycogen accumulation, they are seen in uncontrolled diabetes mellitus.